I also just wanted to mention a lot of questions have come up about treatment dollars, and Joni was talking last night about how we get, each community in Montana gets federal flow-through funds, and we here in Missoula, through Western Montana Addiction Services in Missoula, Ravalli, and Mineral, and actually up in Lake County, get state block grant funds and each county gets those funds based on a per capita. And we receive those funds to provide treatment for folks who are underinsured or non-insured, and those funds have a cap. So one of the most common complaints that I get as a clinical director at WEMAS is, why are people waiting 4 to 5 months to get into treatment? And the answer is because there are a lot of people that need treatment and there are limited funds. So it's really up to each individual, state agency to figure out how to most expediently and that means the same thing. What's that other word I'm looking for? Efficiently spend treatment dollars so that we can treat as many people as possible in a very high quality and effective way. If anybody has any other questions about that, I'm happy to talk to you more about that at the break. So, without further ado, I believe that Kay is going to introduce Randy, and I will be introducing Steve.
Hello. Is that working? Okay. It's really my honor to introduce Randy Secreast to you. Dr. Secreast is the medical director of the Montana Spine and Pain Center at St. Patrick Hospital and Health Sciences Center. He is board certified in orthopedic surgery and has practiced in Montana since 1987. Randy has clinical and research interests in the management of chronic musculoskeletal pain states and the incorporation of integrative healthcare modalities in the treatment of chronic pain. I have had the privilege of working with Dr. Secreast in his role as chair of the Advisory Council for the Montana Pain Initiative. Randy is a visionary who understands the big picture of chronic pain, mental health, and addiction. He played a significant part in planning this conference and is an advocate for chronic pain patients. It is my pleasure to turn the mic over to Dr. Secreast. Yeah, you got to introduce Steve.
Just want to make sure you're coming up, Steve. Yes? Yeah. And it's my pleasure to introduce Dr. Steve Kempel, who's a graduate of the Texas College of Osteopathic Medicine. He's trained in 2 specialties. He completed a residency in family medicine at the Mesa General Hospital in Arizona, following which he decided to change direction entirely and completed an anesthesiology residency at the University of Arizona. Dr. Kempel took the direct route to Missoula 20 years ago and began his career in anesthesiology. He's been providing pain management care since that time as well. His recognition of the need for a formalized pain management program inspired him to form the first private practice interdisciplinary pain program in Missoula in 2005, now known as the Advanced Pain and Spine Institute. Dr. Kempel is also involved in planning of this conference. Please welcome Dr. Steve Kempel.
Well, thank you. Is this on?
Yeah, but put it up.
Can you hear me now? Okay, you're at the University of Montana, so with this question on the board, you may think you've wandered into your first course in philosophy, and this is an existential question. But really, my goals here today, this morning, is to, both Steve and I's goals are to really sort of set your thoughts and aspirations, I guess, to try to get the most out of today. And we're trying to guide that process to some degree, because what we would really like to do is not just perceive this conference as a didactic sort of lecture. We're here to teach you how to do something. It's really a working conference that we're here to begin a conversation that really needs to continue after this meeting. Now, the group that sort of formed this coalition, so to speak, came together as an ad hoc committee, I think, that just sort of formed as a grassroots effort because people were beginning to realize the same thing. And that same thing is that we all began to perceive that there's a real deadly triad that all of us were seeing from our own viewpoint. So Steve and I had numerous conversations about the problems that we're seeing with managing chronic pain in the face of patients who have inadequate mental health services and inadequate substance abuse services. And these patients didn't know where to turn, they didn't know how to access these services, and they just weren't getting what they needed, so that it made the job of taking care of them as chronic pain patients incredibly difficult. And I think that once we began to have these conversations with other folks in the mental health community and in the substance community, we found that we had a lot of overlap in the sense that they saw the problem from a different stance. They saw the problem as managing a substance patient whose chronic pain physician continues to give them opiates when I'm just sitting here thinking, what are you doing? And the mental health folks would say, I'm managing this patient, trying to manage this patient, and I can't get their substance use controlled. And in some cases, they have uncontrolled pain that nobody will take care of, and that makes them uncontrollable from my standpoint. So it became quickly obvious that all of us had the same problem, just with a different slant. And I think that all of us began to realize that the problem really is much larger than any of us together had thought. And I think that we began to conceive of this problem of the deadly triad of chronic pain, falling into amplification of other problems, including substance use and mental health problems, and vice versa, no matter which way you came at the problem. So our goals with this conference were really to sit down and begin a conversation of how we're going to look at this problem in a much broader context and look at it from the standpoint of a disease process that's not just a chronic pain disease process. It's not just a mental health disease process. And in most cases, it's not even just a substance abuse problem. It really is a disease process in itself that needs a solution. And part of that solution is coordinating care and beginning a conversation that leads us to that, so that we understand these patients in a much broader way, no matter what aspect of their care we're trying to provide. So we've met for probably, 18 months now, a year, and tried to move this conversation along. And this conference is really, the goal of this conference is really to try to spur that conversation more than anything else. One thing I would like to point out, we couldn't have done this conference without CSAT, and Rick Christensen, who's I think in the audience today, is the prime mover. Once he connected us, Rick runs the organization that has brought the first methadone maintenance clinic to Missoula and now the state of Montana. And without his help connecting us to these resources, this conference would have never occurred. But once we got connected to CSAT, it became obvious that we had some resources and a way forward. So thanks for that, Rick, wherever you are. I know you're here somewhere. Thanks. So that's really where we want to go today. Now, the group that came together and really tried to define, what are our concerns? What are the four things that we want everybody to take away from this meeting today? And everybody pretty much identified the same things. The first is obviously access to treatment. I think some of those questions have already come up from our discussion last night. You know, where are the dollars going to come from? Where are the resources? How do you get to those resources? I think we really became interested in our role as coordination of care. How are we going to improve that? Because that's something that we can do. And one of the reasons that we really wanted to focus on this three-county area when this process started was that we really wanted to have the people in the room that could create this coordination. We really resisted doing a more regional or larger conference simply because we wanted one of the things that come out of this meeting were groups to form of people that were going to be working together and needed to be working together on an ongoing basis. So one of the things that our concerns were is how do we get there? How do we get those groups to form? I think quality of treatment is clearly always a problem, and that goes back to access and it goes back to resources. And I think all of the things that we're trying to do are really ultimately trying to drive quality of care. And finally, community awareness. I think that, again, last night when you heard the Attorney General, community awareness is being built for prescription drug abuse. And the message is that everything hinges around stopping prescription drug abuse. I think it's only part of the story. I think the broader picture is that prescription drug abuse is occurring, absolutely. But we also have other problems that this unilateral sort of attack on prescription drug abuse is going to have some collateral damage. And the collateral damage may be in the chronic pain patients, and it may be in some of the services for mental health disease and those sorts of things. So I think just viewing this as purely a prescription drug abuse problem is problematic. And one of the things that we wanted to do with this conference is really raise the awareness that we're not just talking about prescription drug abuse. We're talking about a much broader problem with a much broader social context. And we need to keep that in mind as we go forward. So the goals of this conference really, if we're going to look at the problem as a combination of pain, mental health, and addiction, I mean, our goals are really to reduce the opiate misuse, abuse, and addiction. I mean, that's what everybody wants to do. We don't want to throw the baby out with the bathwater. We don't want to create so much collateral damage that we're really damaging other parts of the community. And I think any one of these areas is at risk for that. No matter which one dominates, each one of these other areas are at risk for collateral damage. I think clearly you need to educate healthcare providers about the problem. I don't think, again, I think that healthcare providers, what we see in the chronic pain community is that the healthcare providers tend to be, and I'm talking about physicians here because those are the folks that we tend to deal with on an ongoing basis. Sometimes we see the process as simply a process where it's black or white. You know, either opiates are all the way good and they belong to everybody, or opiates are all bad and they should never be used for chronic pain, regardless of what the problem is. So I think what we would like to do is educate the providers enough to where they can make a rational decision and manage the problems in a way that we get balanced care rather than simply one-sided care. And I think the other piece that clearly needs to be understood by physicians especially is the interplay of the mental health, the substance piece, and the chronic pain, and not just see this as a black or white problem. And finally, I think what we really want to have happen after this meeting today is that this be the instigating event that actually serves to create an effective network that we can begin to coordinate these three domains together. So if that occurs by the end of the day, this will be a raving success. And Steve and I are going to come back at the end of the day and try to stimulate you to create an action plan for yourself and for your community so that we can leave this meeting with some real goals and some real action items that we can act on and get done. So I think Tamara's going to talk to you a bit about, she's fairly obsessive, so she already has a plan into the future of how that's going to happen. So she will give you your marching orders this afternoon before you leave, I think. So with that, I think I'll turn it over to Steve and let you enjoy the day. Thank you.
Thank you. First of all, I just want to say that I want to welcome everyone here today. It's great to see such a nice group of people, a large crowd, of very concerned people that really see we have an issue and a problem on many different aspects, as Randy just mentioned, and that we definitely want to try to work on this. So I want to welcome everyone to addressing chronic pain and addiction. And before I really get started, there was a core group of people who met for 18 months, as Randy stated, who worked very, very hard. And they missed work, they left work, they went and they met and they decided to bring this to fruition. And it took a lot of energy and a lot of time. I was not one of those people. I was working, but I was not at all these meetings. And so I cannot take the credit. But I would like to take just a second to have the people stand who have really gone to all these meetings, Randy, you as well, who have worked, and I want an applause for all the people who have really put this thing together. That's why we're here today. So thank you all very, very much. Without those people's hard work, this would not be happening today. You know, as a pain physician, like many practitioners or physicians or mental health professionals or pharmacists in this audience today, we all are used to dealing with people with different types of chronic pain. And chronic pain comes in many forms, in many faces. And one of the things, you know, I have many different tools in my armamentarium bag to help people with pain. You know, I have medication management. I have needles that I can stick in people and try to help them. I have implantable therapy. There's physical therapy. There's a lot of psychological therapy out there that can be incredibly beneficial. But one of the things that we can do to help people as pain physicians are opioids or narcotics. And opioids and narcotics, not to just dwell on that, but it has helped millions and millions and millions of Americans. It's helped people all over the world. It has helped the patient who comes in that can't work anymore, who has no self-esteem because he cannot work to make the money for his family. And he went from making X amount of money a month to now almost nothing, possibly living on assistance programs. So it has definitely been a huge help for those people. It's helped just to get away from this chronic nagging pain that will not go away. It's helped people in their personal lives, and it's helped people in their social relationships, because when you have chronic pain, you often don't have a personal life. You often don't have a social life any longer. You just have a painful life, and it can be miserable. And as I look out here, I have several patients in the audience, and I know that they know exactly what I'm talking about. But unfortunately, sometimes narcotics, which can be incredibly helpful, can become incredibly dangerous. And they can hurt a lot of people, hurt a lot of families. And this arises for lots of different reasons. One of the reasons it arises is the physicians, okay, and the providers. Because sometimes we write medications for people the wrong way, we write the wrong medicine for the wrong patient, and we don't monitor them closely, and we get hoodwinked. Sometimes these patients take these medications and they divert them, and we don't know they're diverting them. And we try real hard to make sure that they're not diverting them. We do urine tests. We have a drug contract. It's incredibly long. It's 2 pages. I read every line. I tell them, you can't divert this. You can't abuse this. You can't sell this. You can't leave it laying around for people to break into your home and get. You can't leave it laying around for children to get and teenagers, because once we start down this route, it is deadly. And it still seems to happen. You know, we all have examples. I mean, with all the people that I see in this room who are practitioners, mental health providers, and others, we all have examples. I'm going to give you a couple of mine, just real quickly. You know, when you think of people abusing narcotics, sometimes you come up with a mindset like a young person, 20s or 30s, you know. You might think of a young guy coming in with dreadlocks, whatever, okay? Not true. What do you do when you have your little 72-year-old male that's in your office and his MRI looks like he has bamboo spine? It looks horrible. He can barely bend over. He hurts every day, and you're writing him methadone. He never calls up early. He never, says, I'm out of it. I lost it. I had it in my lap, and I was going to church, and I got out of the car, and it dropped, and it all fell in the gravel. He never does that. He's just perfect. And you do a urine screen on him, and there's no methadone in his urine. Where's his methadone? Well, maybe this is why his little wife, who comes in with him every time, is asleep in the chair. And then you discuss this with him, and you find out, yeah, I've been giving it to her because she hurts worse than I do. And it's like, well, why didn't you come and talk to me about this? Well, I didn't know how to say it. So it doesn't have to be a young person. There are people who come into your clinic that have physical findings that look like they should definitely have pain, and you go along with it, and you do everything you normally do, and then you find out that they took your prescription and they went home and they tried to reproduce it on the internet, then they tried to forge your name, and you had a very, very astute pharmacist call you up and say, there's something wrong here. This is another way we find out how these things are happening. One more example is that you get called to see a patient in the hospital because he has had a back surgery. He's a young man, and they can't control his pain after surgery. And he just had a normal fusion, They do this all the time. It's done very frequently. But he's requiring many, many more narcotics, and he's having a lot of pain behavior. So you go in and you see this gentleman, and he finally levels with you. He goes, Doc, I get OxyContin off the street, 100 milligrams at a time, and I chew it. You chew 100 milligrams. I do. I do it 3 times a day. So in 20 minutes, you get 100 milligrams of OxyContin. And you don't pass out. You don't get sleepy. You don't, stop breathing. No. Well, maybe this is the reason why that what we're doing right now in the hospital is not working. So you put him on a very strict regimen. I mean, you got to go through and put an epidural in him in the hospital to try to control his pain. You have to do all these different things. And then when you get him home, he comes in to see you. And you already know he's got a problem. So you get mental health involved, with psych, and you get PT involved. You get him on a very strict program. You're reading the riot act on these narcotics because he has to be on some because he just had a big spinal surgery. And you try to watch him very, very closely. He agrees to everything. And you choose a dose that you feel like is appropriate for him, and you're going to watch him like a hawk. 3 days later, you get a phone call from his wife, this sweet little gal who says, I just wanted to tell you that he just went to one of the urgent cares in town and just loaded up on OxyContin. And I'm like, what? Yeah. And I said, and did he tell them that he has a drug contract with me and that we got him on a program and we're really trying to watch him and help him? And they're like, yes. So then you call the patient up and you're like livid, and all these emotions go through your mind because you gave him your heart, you gave him everything you could, you tried to help him, but his addiction has taken over. So what are you going to do with him? You're going to kick him out of your clinic? You're going to tell him you're done? Are you going to tell him that you'll still see him and write all of his adjuvant medications, which are non-narcotic meds, but just not the narcotics? So we have a real issue and a real problem. And I know every one of you have these same exact cases. We hear them every day. And with that in mind, I recently spoke with a detective here in Missoula, and I would just like to give you a few little statistics of what we're dealing with. This is just a few things, okay, just to kind of get an idea. Recently, a male had an overdose after purchasing methadone from someone on the street, and the seller is now being considered for negligent homicide, okay? So how'd the methadone get on the street? Well, we wrote the prescription, one of us. I think Dr. Irby said last night, you can go get medications all over. He knows where you can get them. I'm sure I have patients on the street who are selling their meds. I do everything I can to avoid it. I try very hard. I know it's happening. In the past 9 months, Missoula's had 3 armed robberies at local pharmacies, 14 reports of fraudulently obtaining dangerous drugs, 10 reports of possession of dangerous drugs. Now, what is fraudulently, obtaining? That means that fraudulently obtaining can range anywhere from forgery to stolen prescriptions to buying and receiving these medications on the street, okay? Possession means that these people are not legally allowed to have these drugs in their possession, okay? So that's some of the terms that I wasn't aware of because there's been 10 reports of possession of dangerous drugs. There's been 2 counts of criminal distribution of dangerous drugs. There's been 3 burglaries to area medical facilities to obtain narcotics. And the majority of these cases involve medical personnel as the suspect. And these are just in the city of Missoula. This is not Missoula County. This is not our surrounding counties. This is not our surrounding cities, Hamilton and Polson and Ronan and Superior and Deer Lodge. This is just Missoula. And this is only what we know of. Can you imagine all the cases that go on every day that we have no idea about? So this is just this is just telling us some of our issues. So hopefully today, before we all leave, I hope that we all have a better understanding of how to prescribe these medications. I hope we have a better understanding of how to monitor these medications. I hope we have a better understanding of what mental health facilities are out there when we have patients that come in that are already on these medicines, and how to network with each other, and how to take this big problem that we have and take all the small entities, healthcare, mental health, prescribers, everyone, and pull this all together so that we can truly make a big impact, not only in our community, but, in this state. And maybe we'll be the leaders in the country. I don't know. We'll see. But that's hopefully what our goal will be. Thank you.
I think we have a few minutes maybe for a couple of questions, if there are any questions about today's events, and then we'll get started with today's events. So, yes.
My name is Stephanie Quick, and I do adult case management in Superior for the Mental Health Center. And I just wanted to say a couple things that I see with folks that come through our door, and it doesn't necessarily that I have an answer or anything, but something to think about. So number one is, I think we have a society that tends to lean towards a pill as an answer to any kind of problem that you have. So we kind of have this societal message that, if you have a problem, a pill will fix it. And so I was thinking, like when Tamara was talking about a publicity campaign, I think part of that needs to be maybe addressing that medication isn't always the answer. And then the second thing would be, because I work with low-income families, it's often the lack of insurance. And so a lot of these people will get prescribed medication because it's a lot cheaper than getting a cortisone shot, getting physical therapy, once a week, or ultimately having surgery because they can't afford to have this done. And so I think that also, tends to lead towards an addiction because they're started on a cheap medication to get them by, and then it just progresses from there. And so I do work closely like with Mineral Community Hospital and Tamarack Clinic, as well as the pain clinics, because they have charity care programs to take these people in and start to give them education about what they're taking and the long-term side effects of it, and also ultimately to get them some kind of treatment, real treatment, to address their problem so that then they can move forward from there and start to have a better quality of life. So I guess I just want to throw that out as, I like the movement in our country for everyone to be insured. I absolutely think that, all these families, they deserve to go in and get the care that we would get. But the second thing is I really do think as a society, we need to rethink leaning towards medication as the solution to all of our problems.
Yes, ma'am. I'm assuming that wasn't a question then. Yes, ma'am.
The one gap, and maybe I'm inattentive, I see here is law enforcement, because in two cases, one in my own family and one as a CASA worker, I've seen a punitive approach to this. And immediately you have a problem with whoever is using the drugs, and they become very defensive, or they leave, or whatever. So somehow we've got to include law enforcement in this in order to catch this problem and treat it in a less punitive way, because the threat is you're going to jail, and that isn't going to help anybody get better. Anyway, that's all.
Law enforcement may be here undercover.
Well, and I would like to address, just so you know, we invited law enforcement to come. And, sometimes they're out there on the streets doing their safety thing, and today's a work day. So it may be why they didn't, I'm sure there are some here, but anyway, that's partly, I think, what. But we definitely, I just want you to know, we totally invited them to come.
And they were part of our planning committee as well. So they'll remain involved.
And the Attorney General's here. As he said, he's the top cop. So I think that suggests at least the interest level anyway.
Yeah, my point is, let's take a less punitive approach.
Agreed.
Towards addicts.
Time for one more question
So, Randy,
or comment.
I have a question.
Oh, yes, ma'am.
How many people that you put on prescriptive pain addictive medication, how many of them become addicted?
None of our patients. I have no idea. That's the problem. I have no idea.
Okay, but don't we need to know that answer to be able to deal with this?
You know, the literature would suggest that 10% of people have an addictive personality and are doomed to addiction. I don't know that that number is credible or valid, but that's the number that's thrown away. I think when you look at the statistics for opiate misuse or medication misuse, it depends on how you define it, but then you're looking at 60 to 70%. So, but the question is, I mean, how many days a week do you forget to take your blood pressure medication and might double up on it thinking it's going to help you? If you do that with opiates, that's opiate misuse. So all of a sudden you're an addict. Thank you very much.
Well, I'll thank Randy for revealing one of my secrets. I thought for sure I was hiding my obsessive tendencies from all of you, but not anymore. Oh, yes, it's that you recognize it in yourself, so you see it in me. Thank you so much. It's my pleasure to introduce the next speaker, Dr. Daniel Knotts. He practices addiction medicine and psychiatry at Montana State Hospital in Warm Springs. In addition, and through the support of the Addictive and Mental Disorders Division, he also provides services at Western Montana Addiction Services, addressing the needs of our co-occurring clients, including psychiatric medication management and buprenorphine maintenance. He received his medical degree from the University of Michigan in 1969, where he also completed his internal medicine residency. And concurrently, through the University of British Columbia, he completed 1.5 years of a psychiatric residency. He's been practicing addiction medicine since 1986 and was the medical director for one of the first inpatient hospital-based units in Washington State. In Montana, Dr. Knotts has played instrumental roles in assisting the merger of addiction services with psychiatry at Benefice Healthcare, Montana Chemical Dependency Center, and now at the Montana State Hospital. In addition, he's provided consultative services for complex pain patients and patients requiring withdrawal management. He provides training for physicians focusing on treating pain without addiction. Dr. Knotts is certified by the American Society of Addiction Medicine and helped to create the first edition of the ASAM patient placement criteria. It's with great pleasure that I welcome Dr. Dan.
Thank you very much. Thank you very much. It's wonderful to see so many familiar faces that I've worked with over the years here in Montana in the last 17 years, and I've been given incredible opportunities to actually bridge a variety of systems that we often don't bridge. I think that's how I decided to come up with a hybrid. I was thinking triaccurring because I was speaking to Dr. Sechrist with the terrible triad. I don't know if it's really a terrible triad. It's probably essentially the most common triad that we see in private practice, and that is pain, substance use disorders, and depression and anxiety. Those three areas almost dominate primary care practice. Obviously, there are multiple etiologies for those three problems. One thing, and I would like to mention at this point, language drives a lot of our behavior. It drives how our communities think about our patients, how our consultants think about our patients, and so on. We respond differently if we label someone as an addict versus whether we say this person has a substance use disorder. I think those are some of the things that maybe we should look at in how we can better serve this population. A complex pain patient who you label an addict, a lot of doors begin automatically closing. And it's one of the reasons that I was excited about presenting at this conference, because the Montana State Hospital, our state psychiatric hospital, in many ways has become the default service to care for complex patients that nobody wants to take care of anymore. Which is unfortunate, because we lack, as we're in a rural area, we lack all the resources, certainly of our general acute care hospitals. So in a sense, and Randy spoke to this as well, that we're talking about overlapping problems. And often our focus, we've got our pain people, we've got our addiction people, and we've got our medical care. And they rarely interact. But so for good patient care, essentially our focus really needs to be in those areas of those three circles in the Venn diagram where they overlap. How do we do that? And I had a wonderful opportunity in the late 80s, early 90s to work with the American Society of Addiction Medicine and the National Council on Addiction Treatment Providers. And we realized that there was the medical component to addictions treatment and the traditional addiction counselor, social worker orientation to addictions care. And they were relatively competitive. And we said, this isn't good. It's not good for patient care. So we got together and started talking. And I see this in many respects as similar. It was incredible, because what it did is create the American Society of Addiction Medicine patient placement criteria. And that created a language in which multiple disciplines could communicate. It also basically brought to the forefront a biopsychosocial model, where we looked at a patient from a point of view of 6 dimensions. Now, there are other places we can look at people from multiple dimensions. DSM-4, which was quite a change from 3, delineated domains under Dimension 4. So how do we get at, approaching this population as in a biopsychosocial way? This is different from what we do as physicians. And you need to realize that those of you who are more biopsychosocial oriented, a physician does sort of a traditional history and physical. Issues around social history are usually minimally addressed. Okay, it's not integrated into essentially a patient's presenting problems. So, and then, we have to give our doctors some slack too. Yes, as physicians, we sometimes are at fault in perhaps not watching our patients closely enough, perhaps prescribing too much, not getting into all the other issues. And so why is that? Some of it's basically related to economics, that the systems in place do not necessarily allow that physician really to spend enough time to fully understand their patients. So how do we get around that? And I think that in a part of my talk today, I'm hoping that I can, one, confuse you, seriously, and create some questions and maybe some new ideas on how we can work together. obviously, and we can take from different models. I mean, we can take from a community mental health model. I don't know how many of you realize, you know, that currently in this country we have 33,000 open positions for psychiatrists in the United States. So we got to look at ways of extending, you know, the skills of our psychiatrists, and that other people have to take on some of their responsibilities in a community psychiatry model. I think we can learn from that. And Tamara, actually, at some point, maybe in a breakout session, she can explain her experience when she was early in her career of working enmeshed in a family practice group. So in a sense, with an enmeshment of a professional in that setting, you create a person who has skills in behavioral health, in addiction medicine, in dealing with grief and loss issues. And essentially, the doctor, he can still be efficient, do his brief visits, but like a lab test, he says, you need to be screened, you need to address some of these issues, so I want you to see this social worker master's level professional in our practice. So, and we'll get to some of the barriers why that is difficult to do. So essentially what we want to do is broaden our database, perhaps changing how we do things as doctors, nurse practitioners, and PAs, because we're all prescriptive providers. That, you know, that we're going to be confident in the decisions we're making in how we manage our patients. This is the breakdown, and those of you who certainly do 5-axis diagnoses, I encourage you to be more specific in when you're dealing with complex patients, in actually going through the 9 domains and basically identifying problems in those areas versus just as in DSM-3, where we basically just said, well, occupational problems, just lost his job and has chronic pain. Be more, you know, go through each one, get obsessive about it. Now the ASAM PPC, or patient placement criteria, there are 6 dimensions. Those dimensions have been modified by the American, I believe, Association of Community Psychiatry. So, and this is a derivation of that. And it still is effective for essentially approaching any patient, whether their primary diagnosis is a substance use disorder, a mental health issue, or primarily a medical issue. The first dimension traditionally was that of intoxication withdrawal. That was expanded to include acute psychiatric status. And though, you know, we generally don't think in our chronic pain patients of acuity, lethality, and dangerousness issues, from my perspective, which is somewhat biased, the patients who present to our state hospital are often there because they're a threat to themselves or others, and often it is related to their pain management, not getting their pain management, or possibly threatening harm to self and others while under the influence of their medical management. You know, and when we look at substance use, we also need to look at, you know, we're looking today, we're focusing on either illicit or use of illicit drugs that perhaps have been prescribed but still misused. We have to be also looking at the influence of illicit drugs, which may may be used in combination with our prescribed medication. The interactions certainly may lead to significant substance use or complex substance-induced disorders. One of the shifts from DSM-3 to DSM-4 was the development of substance use-induced disorders. Frankly, mood disorders, psychotic disorders, anxiety disorders, all can be induced by substance use. And what often presents as a primary mental health issue may well indeed be a substance use-induced issue. So again, the importance of developing an adequate database in your decision-making. One of the prior speakers spoke to the effects upon our social networks by pain, as well as potentially how we treat pain. And this also these are issues that we have to look at treating in order to be effective. People become isolated with their pain. People become isolated because of the effects of the medications we provide them. People experience neglect. People are irritable. They're difficult to care for. They may not be able to maintain their level of hygiene that they're accustomed to. Some people just don't want to accept the position they're in with their pain syndrome. How willing are they to adjust their behaviors? Are they ready to change? What stage of change are they in? If they have multiple problems, what stage of change are they in for each problem? It's getting very complex. Who do they trust? Do they trust their physician? And I have a lot of compassion for those doctors out there. A very sweet elderly woman, when I chose to not respond to her request for more pain medication, she said, "Why are you so mean to me? Don't you care about me?" That's very hard to hear. Okay? Because we're caregivers, and we do wish to relieve suffering. Clearly, in our documentation, we're interested in looking at what are the complications, not only of our pain management, but the functional complications of the original injury or illness. What are the factors that potentially lead to development of chronic pain syndrome? Patients who've had abusive developments, whether it's physical, sexual, or emotional, seem to be at risk. Patients with premorbid mood and anxiety disorders. Patients who are not particularly competent in developing social support systems are at risk. Patients who achieve much of their identity by being caretakers, and when they lose that ability, it's almost intolerable that they need to be cared for. People who basically function primarily by their physical skills, not cognitive skills, and when that physical capability is taken away, experience severe loss. Little do we address, I think, or nor do we have the time in the context of a primary care setting necessarily to address the profound grief and loss issues which can occur with pain and significant loss of function, both emotionally and physically. This affects entire family systems. And then we have superimposed the substance-induced issues, not only related to opioids, but potentially drugs used to enhance the effects of opioids, such as benzodiazepines and muscle relaxants. If you study patients with panic disorder who have been maintained on benzodiazepines, 33% of them will become depressed. So sometimes it gets very confusing. Is the patient presenting with symptoms that are due to the original condition, or are those symptoms related to substance use disorder, etc.? We're going to have a big grasshopper year. That's what I'm told. Okay, grief and loss. Some of the issues that for example, I don't know how many of you've cared for surgeons who have a chronic pain issue or who have had an injury that interferes with their ability to practice their trade. They're devastated. Why is it? Because so much of their identity is invested in being a surgeon. And there are many other equivalents all through our society. It affects our ability to interact in our relationships. It affects our ability to be intimate. It affects our role in our family and work, in our friendships. It affects our ability to experience pleasure. It affects our ability to pay attention and concentrate. It affects our ability to be independent. We have a lot of proud people in Montana. It affects our ability to be tolerant. What are the risk factors? Well, genetics. People respond differently to substances, whether they're the ones we prescribe or the ones they expose themselves to legitimately or not. Bill W., when he first drank as a young man, said basically alcohol dissolved the invisible barrier between me and the rest of the world. Patients with opioids will say, the first time I got Lortabs or OxyContin, I knew that was the one for me. I felt great, and I wanted more of it. That was an immediate response. That is, no previous exposure, that is a person who has some genetic predisposition. The other issue is looking at family histories in a sense that we see intergenerational use of substances, as well as intergenerational. For some time, I was worked as a consultant with a medical peer panel for state fund. We had several families where there were at least 3 generations of persons who were in the workers' comp system with the big 3: pain, depression, and substance use disorders. Individuals that are highly narcissistic and antisocial seem, again, to have some predisposition for misuse of legitimately prescribed pain meds. Individual with a high investment in not only careers, but sports and other activities. Oops, what's going on here? Okay, no. Well, I can't get it to go.
What is it supposed to do?
It's no.
Page after page down?
I want to go. Oops. No, wait. Don't want to end. Oh, let's see if we can do it here. Yeah, we got it. Okay. Sorry. Thank you. Again, this is repetitive. There's some variation in what we look at as acute or chronic pain. Clearly, obviously you have an injury or surgery where there's a well-defined period of recovery versus chronic pain where recovery does not occur, pain persists. There are various timelines that are placed on this. Dependence versus abuse versus addiction. Abuse is a term that, frankly, tends to be generalized. We talk about abuse, and it's not clear whether we're talking about abuse diagnostically or dependence. Pseudo-addiction. If basically any one of you comes in to have their gallbladder out, and I, as your physician, undertreat your pain, you are going to be a very unhappy person. You're irritable. You're asking the nurses for more medicine. You're asking the doctor for more medicine. You're coming across as a drug seeker. That's pseudo-addiction. That's our fault. We're inadequately treating pain. And we jump to conclusions when we have problem patients in this area that it's always the patient's fault. It isn't. It may well be how we're interacting with that patient and how we're prescribing to that patient. There's some confusion around opiates and opioids, and I've made some typos in my presentation here. An opiate is basically referring to the natural occurring opioids, which would be essentially morphine and codeine, heroin would be opiates. And opioids is a general category, not including also opiates, but the synthetic opioids. Substance abuse. Basically, any one of these criteria, if it's at least intermittently persistent over a 1-year period, you make a diagnosis of substance abuse. Substance abuse does not necessarily mean that there will be a progression to substance dependence. What's medical dependence? You aren't going to find this in DSM-4, and I'm hoping that there's at least better differentiation of essentially what used to be called physiologic dependence versus addictive dependence. If we give someone on opioids on a long-term basis, they will become tolerant to their medication. There'll be a reduced effect with a level dose. Eventually, they will say it just doesn't do quite the same thing it used to, doc. And that's variable with individuals. And then withdrawal. If someone's been on an opioid for a long time in a significant dosage, and we stop it, there will be at least some mild withdrawal. And so these are essentially, we've created this. I've created this in my prescriptive practice with this patient. So when does it become addictive? And this is where, again, those individuals who do assessments, if I refer an individual who I think might have a substance use disorder who also I'm treating for chronic pain, and I'm interested in whether they've moved on to that addictive dependence, and I refer them to a traditional chemical dependency program, in that they have tolerance and withdrawal, they have already achieved 2 of the 7 criteria to meet criteria for dependence. So what have we done? We've set ourselves up, in a sense, by the way the criteria are developed, to overdiagnose addictive dependence in chronic pain patients. Okay? So this is something you may want to, if you're not familiar with necessarily the chemical dependency provider you're working with, to actually have a discussion with them. Look, they already, just because of the way I treat them, are tolerant and will have withdrawal. They need more than 1 other of the 7 to meet that. Now, but this, I believe, is one of the reasons. When we try to put an individual who, say, has tolerance, withdrawal, and then 1 of the other 7 criteria into our traditional addiction treatment groups, what did they tell us? I don't fit in. I don't fit in. I don't do those things. I don't belong here. I'm not going to do this. Then we have an uncooperative patient. Well, the fit's wrong. So more use than intended. Well, sometimes in the way we prescribe, maybe I didn't prescribe adequate amounts, or maybe maybe I said 30 milligrams of MS Contin, or excuse me, let's use Percocet, and I said Q6 hours PRN, but I really only expected them to use 2 a day, so I wrote for half of what the amount if they were to use it 4 times a day. That is not an uncommon problem that we have in our prescriptive practice. So then the doc says, well, I really only anticipated you were only going to use, that you'd use, that would last for a month, and here you are back at 15 days. Unsuccessful efforts to cut down. Many of our patients do not like the feelings of opioids. And the so-called normals, actually that is common. They say, I don't like the way I feel on these medications, so I've tried to take less. So some of these other issues, and that's why there's the importance of that dialogue between the medical providers, the prescriptive providers, and the people that are going to do your assessments. That they have an understanding that things are a little different here than when we assess those pure alcoholics, which there aren't many left, and or a cannabis dependent person, or a methamphetamine dependent person. Activities given up because of use. Well, that's hard to sort out. There may be a lot of activities that have been given up because of pain and functional issues. So that requires some skill. Uses despite negative effects. Well, even when we appropriately use opioids, there may be some negative effects, but we still take it because, bottom line, we're more comfortable, we can function at a higher level, and have a life. So who should direct treatment? I think this is and I think this is should this be, Dr. Seacrest, and we spoke to the specialized programs we have here in Missoula, which is wonderful. But in reality, there probably, aren't going to be enough specialized programs to take care of it. And I know some of our pain clinic providers have said, we can't take care of everybody. So maybe we should be looking at them more, what's realistic? Should they be in a consultative role? Often, I think those who work in the workers' comp arena feel like they're the ones that are really trying to manage the patients. Managed care entities, sometimes we feel that way. Is it the payer? Because they're only going to pay for so much, but they won't pay for what we think the patient needs. So something gets out pretty far. Healthcare reform is relevant to the management of this population. Again, looking at what works in community mental health. I'm sure some of you here probably work on PAC teams or ACT teams, assertive community treatment, where actually you have teams, clinical teams, that go out and see patients in their own settings, multidisciplinary, and so on. Some of our pain patients may benefit from that type of model. Home health may be incredibly helpful in working with this population. It also gives you an opportunity to observe these patients in their own settings. Is there a place for residential care in the management of these patients? I think there is. The individuals, for example, that do get admitted to Montana State Hospital, they're in a controlled environment. They usually have been committed. So there are, you can basically, it creates a setting where you can direct care without the patient being able to leave. That's the reality. Hopefully in one of the breakout sections I can share some clinical stories with you as far as what has happened with patients who are on extremely high doses of opioids, with significant depression, who with withdrawal from opioids actually functionally improve dramatically and come to a place where their pain is actually no worse. The pain's still there, but no worse than what it was when they were on high doses of opioids. It can become difficult to differentiate what is related to our treatment versus related to the original condition we were treating. Documentation. How do we document? I think this is when I've done medical peer review regarding complex pain patients, one of the challenges we face is lack of adequate documentation, not speaking to function, not speaking to observed behavior, not documenting collateral information provided by family or other significant others. And what are the red flags? Where are we? Okay. Most predictive in raising a suspicion of addiction in this population is selling your drugs. And poverty, and we haven't talked about poverty. Those income, if you get on workers' comp, the best, or on disability for an injury, you're probably going to get about 2/3 of what you were making. I think we'd all have some difficulty if tomorrow we all got 2/3 less than we're getting today. I think we'd have trouble making our bills. So that puts us at risk. So along with selling prescription drugs would be symptom exaggeration to get more than I need so I can take care of my pain plus sell some. Okay? In our smaller communities, people who wish to take advantage of our patients know everybody that's on pain meds. Forgery, stealing or borrowing drugs from another patient. Injecting oral formulations, obtaining prescription drugs from non-medical sources, the street. Multiple unsanctioned dose escalations. You know, you tolerate, generally you tolerate a few, you counsel the patient, but if it continues, it probably is very predictive that there is a substance use disorder. Repeated episodes of lost prescriptions. Over and over. Less predictive. Complaining about the need for higher dosages. Drug hoarding. If I'm feeling well, I better save up my meds. Requesting specific drugs. I'm allergic to codeine and Lortabs, but I really do well with Percocet. Prescriptions from other physicians. This is where our prescription monitoring plan is needed. Being your own doctor. Even if it's appropriate, it can be a red flag. Essentially, encourage your patients to talk with you and get approval to make changes. Our patients are intelligent. They usually, and we should support them, but make sure you're included in the decision making. Unapproved use of the drug. So, I found that when I take the medication, that everything's better. I can cope with my kids. My wife and I get along better. And sometimes it gets a little gray. So, medically dependent. They don't lose control. One of the simplest definitions of addiction or a substance dependence is the inconsistent inability to control use. It isn't like they misuse their medications every day. There are intermittent periods when they take more or use inappropriately. Use causes problems. When our patients that are doing well, they don't cause problems. It causes less problems. Use continues despite problems. If you've been in several auto accidents and it's apparently related to your misuse of your prescription drugs, that's a problem. Quality of life improved. Generally, our patients that we're effectively treating, it's clear their quality of life has improved. This is spring in Montana. System issues. And I think, this is so, I think there are almost 40 providers that are here today, and that's a dramatic shift. I've presented at these types of conferences previously, and we've had 1 or 2 providers show up. So I think we're saying, gee, these people are patients too with problems that we have to learn how to better address. I have concern. The lady was, yes, law enforcement needs to be involved. To what degree do they have to be involved that we create punitive consequences, however? People need treatment. There are lack of dollars for effective substance use treatment. There's lack of resources for dealing with complex patients, whether they're co-occurring patients or whether they're tri-occurring patients with significant medical or pain issues. One of the traps that we got into, and the older physicians here, it was probably in the early 90s, when JACO, the Joint Commission on Accreditation of Hospital Organizations, basically said, doctors are not effectively treating pain. We're not assessing pain adequately in our hospitals, and we have to change that. And that was good. That was good. Raised our awareness. However, it also created a situation where patients said, well, you're not effectively treating my pain, doctor, and if, I can sue you if you don't do that. So it created a situation where docs basically were more vulnerable to overprescribing. And it also drove many docs, and that is in there are clinics in our state where doctors will not prescribe certain opioids, or some doctors won't prescribe opioids at all. Additionally, and again, this would be a separate conference, we've had lack of opioid maintenance therapy in our state. If we have individuals who have opioid dependence and it becomes clear that their pain issue does not warrant opioid maintenance therapy, how do we essentially effectively treat these individuals? They may require brief, subacute, or chronic opioid maintenance therapy with either buprenorphine or methadone. Only recently have we had methadone services in the state of Montana. Buprenorphine's been available since 2002, but we have limited providers, and most of those providers are unable to take further patients. Sometimes in our clinics and our hospitals, our administrators aren't especially wild about us working with this population. It isn't a population that necessarily generates a lot of money for the institution. But there are many, many, many indirect benefits. So, non-malignant pain. Don't start with opiates or opioids. There's my typo. In an ideal world, if someone comes to you as a provider and you say essentially, gosh, I can't justify the continuation of chronic opioids in this individual. So what do? You can detoxify them and transfer them to other medications. But the exposure and essentially the alteration of our receptor systems in our brain sometimes makes that very difficult. And again, we come back to they may benefit from at least short-term opioid maintenance. One of the things we have to be careful in our prescriptive practice is in being too aggressive in withdrawing or stopping the prescription of our opioid medications may drive them to the street, essentially buying illicit substances illegally. There are a variety of chronic pain issues. Probably the predominating issues that are seen in primary care practices are back pain, headaches, fibromyalgia, in a variety of other conditions, or the residual of multiple injuries. We're familiar with all the non-opiate options. Tramadol is beware. Originally, that's Ultram. This was a drug that was marketed as being relatively safe. However, it is a weak mu receptor agonist, and clearly there's abuse. It also, if abused, misused, there's potential for seizures, psychosis, and in combination with SSRI antidepressants, it can result in a serotonin syndrome. So what are non-medication strategies? And again, working in collaboration with our counselors, our psychologists, and in addressing the psychosocial issues. Group and individual therapy. What kinds of group and individual psychotherapy? You know, clearly in patients who have functional impairments and pain, pacing is extremely important. You know, they may be able to do the same things they did before if they break up their routines. Multitask. Motivational enhancement, basically working where the patient's at. What stage of change are they? There are specific strategies for each stage of change. If you don't use the right strategy, you aren't going to see anything happen. That's a provider problem. Cognitive therapy, and especially the application, I think, you know, along with pain, depression, anxiety, and all the psychosocial factors we've alluded to, emotional dysregulation is common. DBT, dialectical behavioral therapy, a form of cognitive behavioral therapy. Probably very effective in this population. Family therapy. Bringing the family in. One, it's the opportunity to get collateral information, but they're struggling as well. Exercise. Acupuncture, other modalities, massage therapy, occupational and physical therapies. So if we're going to prescribe opioids, we want a specific diagnosis. Where we often get ourselves into trouble is not having a specific diagnosis. And there are systemic problems. In doing some consultative work with one of the hospitals on one of our reservations a few years ago, I was somewhat critical of the initiation of opioid pain management in a person with back pain. And then I was informed that it took them at that time it took them 3 months to get a CT or an MRI. So what do you do for that 3 months? Those are some of the dilemmas that the provider is placed in. Clearly, if you have what you believe an at-risk patient who has acute pain, obviously they need to be effectively treated. But if this is a person that's at risk or you historically have had problems with, then be more precise in your prescribing practice. If you anticipate that their pain is going to last 3 days, give them 3 days of medication and ask them to come back. And reassess the patient. These are labor-intensive patients, and that is part of the problem. Terminal illness, addiction does occur, or dependence does occur with terminal illness. So how do you create enough structure so that you can still effectively treat that individual's pain? It's all about structure, accountability, and so on. We really have to be very creative. And avoid opioids and chronic nonspecific pain. Basically pain where we don't have a diagnosis. Difficult to get people off chronic opioids, but buprenorphine, potentially methadone, can be very helpful in getting people off of chronic opioids. Avoid needles. Those of us that work in substance use disorder treatment realize sometimes the most powerful dependence is the needle itself. So if you have a person that's recovering from a long history of IV substance use, injections, even blood draws, can cause craving for their drug. Okay. Oops. Traditional approaches to controlling pain. Traditionally, we basically try to palliate pain. Modern, we try to prevent pain. Use low doses of opioids. We used to try to use as little as we could. Now, a dose to, adequate levels to effectively improve function. Scheduled dosing is probably the most important thing that I'd encourage our providers to do. PRN dosing in persons who are at risk or with history of substance use disorders, they will always take the PRN. Whose PRN is it anyway? Is it, really? And in hospital settings, you can avoid a lot of the so-called drug-seeking behavior if you just write fixed dosing schedules. We have a med room at Montana State Hospital on our unit, and if a PRN's written, the patient goes to the med room, and then if it's a PRN, a negotiation begins. Some nurses, they will absolutely grill the patient why they really need the medication, versus others will say, okay, sure. So it's that variation. It's a crazy maker. Effectively treat depression. I've got 1 minute. And there's a circular relationship. You have more pain, you have more depression. Less depression, less pain. And remembering that, it's not enough just to use antidepressants to treat depression. Counseling, support. Our patients tell us, I know what I can do to take care of my pain and my depression. And they're basically telling you they're going to relapse. Clearly, with effective antidepressants, we can reduce analgesic doses sometimes, but I think the other benefits that the patient becomes more interactive in their social network and functionally. And they have a better ability to distract, essentially, if they're less depressed. I think that's where I'm stopping. Okay, this is a Flint Creek Valley, but hopefully in breakouts, and I'll be around through the day, any questions, I'll be happy to address them. Thank you.
So we have 10 minutes for questions.
Would you briefly discuss the use of Suboxone for treating pain?
Okay, Suboxone is the combination of buprenorphine and naloxone. The naloxone is in the tablet basically as a deterrent to prevent the IV use of the preparation. If you were to inject Suboxone, you essentially would potentially precipitate acute withdrawal. Suboxone is a mixed agonist-antagonist. It both stimulates the the opioid receptor, and then at higher levels can actually block the opioid receptor. So that gives it some unique characteristics. Essentially, the ceiling on that is where you get into the primarily the antagonistic effects of the drug is at around 32 milligrams. The ceiling regarding optimum effect of the drug to prevent craving and give a feeling of normality is at about 16 milligrams. The drug for pain management use for pain management is rather limited. Where I found it effective in chronic pain patients is that it usually is helpful in those people who primarily have nonspecific pain. You've generally come to a decision that they probably could manage without opioid pain management, and it's a very effective transition in order to get them off of opioids. It's in my experience at Montana State Hospital, I had several patients who've come in on extraordinarily high doses of opioids, who we've been able to withdraw and actually been able to maintain on rather modest doses of Suboxone and functionally improve dramatically. So it's a role there, but the role is not primary for the management of pain. It's for management of the either withdrawal or the post-acute withdrawal dysphoria.
Other questions?
This is more of a suggestion comment. When you're looking at the pain and the depression, have you thought about how the pain meds interact with and deplete the vitamins out of the body and replacing, doing blood work so that you know what their vitamin levels are? Because these folks don't get out and get into the sun. Their vitamin B goes down, so their energy goes down. Their vitamin D goes down, so their depression hits. Also, the Eastern world medicines, the topical medicines that you can rub on for pain, that can also do a lot to help with that. So maybe combining all of those together could be something that could help, as well as our world medicines.
I agree. Some of the alternative therapies where there's little evidence base, though certainly on case-by-case basis, may be very effective and certainly not harmful. As far as measuring specific vitamin levels, I'm not aware of any evidence that would support that. Clearly, that in this population, nutritional assessment is very important. And certainly vitamin supplementation would not be harmful.
Well, when I'd gone through an illness, and part of that came with depression and pain. And when they took my vitamin D levels, I didn't hardly have any.
Okay.
And after 3 months of extreme high doses of vitamin D3, that took care of the problem. And it was a godsend to me.
Okay, wonderful.
There actually are studies with fibromyalgia that show there's significant deficiencies in a large percentage of people with fibromyalgia. So I think there are studies out there for vitamin D deficiency and pain issues and muscle issues.
Okay, thank you.
Dr. Dan, having worked with you many years ago, I noticed you used to take a stance with substance mood disorders, where you would treat a person for detox, and then they would say to you, well, I have this anxiety. And you used to say, well, let's start you off with treatment and see where that anxiety is in 30 days. Do you still take that stance?
Yeah, I still do. Generally, most of the substance use-related anxiety and mood disorders generally will resolve at somewhere between 3 and 4 weeks. The data on that's much stronger for alcohol and alcohol use disorders. I think we're in regarding to sedative hypnotics, benzodiazepines, and some of the sedative hypnotic muscle relaxants, it can be actually much longer than that. Opioids, I think the time frame is going to be longer. Opioid-related dysphoria, depressive symptoms can go following cessation of high doses of opioids can last for 6 months to a year, if not longer, or lifetime in very chronic individuals. This is a key element in relapse for opioid-dependent individuals. The data in regards to Dave Segerson's question too, the outcomes of treatment with Suboxone and methadone maintenance are extraordinarily positive compared to an abstinence model for chronically opioid-dependent patients.
Doctor, I just had 2 questions. One was how you treat pregnant women, pregnant women in Suboxone, and the second question is how could we ever get a Suboxone provider in Butte?
Okay. Okay. There is, at this point, the FDA does not approve the use of Suboxone or Subutex for treatment of a primary diagnosis of opioid dependence in pregnancy. However, certainly in our education to get a waiver in order to prescribe buprenorphine, we are well indoctrinated in approach to treating pregnant women with Subutex. There's considerable information from Europe on the safety of this drug. Basically, many Suboxone Subutex providers will work with pregnant women on an informed consent basis. My numbers on pregnant women, I've probably participated in delivery of around 30, 35 healthy babies and no significant consequences at this point with the babies.
And I'll just
Or moms.
Oh, sorry. And I'll tell you, I would suggest that you visit the Rickert Benckiser, as I say, table out here, because last night that person who represents them was telling me that there are some online training for providers to do to become certified, and then also, they might be interested in actually providing training. So I would suggest that any of you who would like to have something like that in your city that's not there, visit that table, talk to her, and find out if there's some ways that you can make that more accessible to your providers.
There's both for a physician, it must be an MD or a DO. It's restricted to become, to get a waiver in order to prescribe. If you are an addiction medicine specialist or a addiction psychiatrist, you're essentially grandfathered in. Anyone else who essentially has some board certification is, after an 8-hour course, is eligible to apply for the additional X number to prescribe Suboxone or Subutex.
Okay, thank you very much.